Thank you very much, Soko, and thank you to the organising committee for the opportunity to be involved in this workshop this morning. It's lovely to see some people that I know in the audience, and this session is around translating pharmacoepidemiology evidence to practice. And the focus is on a discussion around the design, development, implementation and evaluation of interventions. So our health systems around the world are changing to address a number of existing challenges, to provide effective but value-based care now and into the future. As you would be aware, there is an increasing array of diagnostic tests, complexity of illnesses, multi-morbidity, interventions. There's so much choice, but there's also many different carers and organisations that are involved in making healthcare what I think is the archetypical complex adaptive system. So thinking about drug discovery and the development of innovative medicines for both the prevention and treatment of human disease, it's really profoundly changed both suffering and morbidity, but also contributed to why we live longer now than our ancestors. But I suppose along with that has come the increasing prevalence of medicines, which has led to significant burden, which is associated with both harm from medicines at an individual patient level, but also at a societal level. And this has led to, I suppose, the focus on considerable efforts to try and improve both our understanding of how medicines are used and also to quantify the benefits and harms associated with medicines, particularly when they're used outside of that clinical trial environment. So trying to really understand both the benefits and harms, again, at a societal and an individual level. As we know, the pharmaceutical industry has collected information on drug use for a very long time. Over the last 3 decades, increasingly medicine data is collected often by national health insurance schemes, hospitals, private health insurers, primary care clinicians. Really a whole range of people are collecting data. And the data now is computerised, and records from these systems, originally designed for financing, administration and reimbursement, are being used to measure the effectiveness and harm from medicines. The electronic data processing has made population-level analysis a reality, not just for the regulatory control or for the pharmaceutical industry, but also for those interested in how we improve the use of medicines for the citizens of our countries. So pharmacoepidemiology, which is really the scientific backbone of therapeutic risk management. The process of assessing a product's benefits and risks, and developing and implementing and evaluating to enhance the overall balance of such benefits. So translating pharmacoepi evidence into practice. So one of those areas is, focused around post-marketing surveillance or the phase 4 studies. And while definitions and regulations vary amongst our countries, and I suppose one of the things that has changed has been this increasing requirement by regulatory agencies to monitor not only safety, but effectiveness of medicines in actual clinical practice. And I think we have some really good recent examples. The gliflozins, for example, being used in type 2 diabetes. Some of those phase 4 trials that were implemented arose because of safety concerns with drugs used for diabetes that went before them, for example, the glitazones. And so we are actually accumulating a lot of evidence from the post-marketing surveillance or phase 4 studies, and it is about effectiveness as well as safety. Obviously, we use a number of different study designs, and they will be the focus of some of the subsequent advanced education sessions today. But you'd be familiar, we use case reports, case series, analysis of secular trends, case-controlled studies, cohort studies, and RCTs. But there's a whole variety of methods, and that's not the focus of this workshop. But automated data linkage and patient registries are increasingly being utilised under the rubric of post-marketing research. And post-marketing studies should not be limited to just safety, but importantly encompass measures of effectiveness. And this post-marketing research data provide data on broader, but also longer-term use. And I think we're very familiar with the fact that over the life cycle of a drug, our knowledge and understanding of both its safety and effectiveness changes. And we can look and include people who are often systematically excluded from controlled clinical trials. So our pharmacoepi information and evidence can help inform practice, and practice informs the methods we use to gather this information and the right methods that we might need to use. We know that there is individual variations in things like drug metabolism, drug-drug interactions, drug-disease interactions, and they all contribute to the effectiveness of a drug and its adverse effect profile. So it's not surprising that some of this data that we will accumulate from our post-marketing research and from our pharmacoepidemiological research to inform how we can enhance and improve outcomes from the medicines that we use. So translating this evidence into practice against a background of an ageing population. And if we think all across Asia, in our country, in Australia, the number of people ageing and who will be over 65 is expected to grow dramatically in the next 50 years. And for the region as a whole, the population in this age group will increase by something like 314%. So as we try and understand and put our epidemiological research into practice, it's against this sort of changing landscape. And commensurate with the ageing population, we'll have increasing chronic disease burden, increasing multimorbidity, increasing polypharmacy. And again, in our clinical trial research, often they're the very people who will be excluded. And polypharmacy changes across time in any one individual patient. From one day to the next, often their medicines are changing. And so it's not a static then, polypharmacy. It changes across time within individuals, and as they age and as they accumulate other morbidities. And information on concomitant therapies is really an important consideration in our pharmacoepidemiological research, and it's going to be important as we think about what interventions to enhance outcomes from medicines and optimise medicines use. If we just think about this changing landscape a little bit and this multimorbidity, some of the research that was done in Australia in the 1980s showed that most people had one chronic disease, and hence this term that was coined comorbidities. It was like they had one main disease and then they had other comorbidities. Now we talk about multimorbidity being the norm, not the exception, in our older people and those with chronic disease. Less than 10% had 3 or more chronic diseases. In a hospital where I work, it was interesting as a patient came in and they had multiple comorbidities. They had airways disease, they had cardiovascular disease, they had 2 cardiologists. But this time they were in for a fractured hip. The cardiologist wasn't even involved But I happened to bump into the cardiologist in the ward, and I said, "Today, you're a comorbidity." He just laughed. He said, "I'm not a comorbidity." But that's the sort of situation where you've got multi-morbidity. Every episode of care, a different condition might be prioritised over another. And this is part of the challenge we've got in pharmacoepi at the moment. Now, increasingly, 40% almost in 2005, and higher numbers now. What this highlights to us, and this is some research that's been done in South Australia, estimated 50 to 80% of those aged over 65 have more than one chronic condition, but over half of these patients will have a comorbid condition that will result in a treatment conflict. And by that I mean, for example, they might have osteoarthritis, and they might have hypertension or diabetes and renal disease, but they need treatment for the pain of their osteoarthritis. But to give a non-steroidal in that setting would be considered a treatment conflict, because it would make the other condition worse. So from the research, we can see that 60% of those people with diabetes have coexisting problems like heart failure, airways disease, gout, and osteoarthritis, 1 in 2. So you can see that there can be often comorbidities that will lead to a drug treatment conflict. And this is important because so much of our research evidence has informed clinical guidelines about specific conditions. So we have guidelines for diabetes, guidelines for atrial fibrillation, guidelines for hypertension. But the patients being treated often have multi-morbidity and many of these conditions coexisting. So we've got increasing use of medicines, increasing duration of therapy, which I think is really important in our methods when we're looking at this in our pharmacoepidemiological research, is because this influences our understanding of the next part of drug-drug interactions and drug-disease interactions, because they happen across time. We might look at one intersection in time, and they might be on one drug, 2 drugs, 3 drugs, but that combination of their therapies and treatments changes often over time when you have multi-morbidity and polypharmacy in an ageing population with chronic disease. But how we see those benefits and harms, even as researchers, even as pharmacoepidemiologists, it would depend on the societal view. It also can vary on the clinician's view. Think the cardiologist. They might be focused on their cardiovascular drugs and harms from those. Our new treatment guidelines in Australia for heart failure now include empagliflozin. But the person who is treated for heart failure is going to be managed by many different clinicians. Many people will be caring for that one person. So the drug started by one doctor may not be the focus of the other doctors and carers for that patient. So we need to think about how we see harms and benefits from our society's perspective, clinicians' perspective, and the patient's perspective. And I think that's really where we gather that evidence from the pharmacoepidemiological research. There's going to be so much data collected from our traditional sources, but also from the clothes we wear, the transactions we make, the places we visit. Most of our smartphones, yesterday I did 12,000 steps. That information is coming from my mobile phone. Many of the doctors are using some of that for patients to record their blood pressures, report medication adherence. We're getting information from everywhere to inform our decision making or may contribute to noise. So this complexity, a lack of integrated information systems, a diverse range of policy makers, administrators, payers, clinicians, patients, their families, and the different settings, whether it be in hospital, in community, in aged care, they're all going to influence the implementation of interventions designed to improve patient outcomes through optimising medicine choices. So, this workshop will focus on the interventions designed to optimise outcomes and minimise harms related to medicines. We know that medicines are the most common therapeutic intervention made in healthcare. The increasing use of medicines has resulted, as I said, in this focus on harm from medicines occurring at the individual patient level and collectively at the societal level. And a lot of our research is focused on better understanding those harms, but also understanding the benefits. As I've said, acknowledging our ageing population, increasing chronic disease, and, I think also the nature of the drugs that we are using is changing. So certainly the wave of new biologics that will be used to treat prevalent chronic conditions. It's something that we're grappling with, particularly in Australia, is the pharmacovigilance around the biologics that are being introduced. Again, particularly in older patients. One of the most common biologics that's been introduced is a drug for the treatment of osteoporosis. Certainly we're using a lot in cancer chemotherapy, in conditions like rheumatoid arthritis and other conditions, but the biologics are becoming increasingly available, and understanding their use is going to be very important. And I think it's going to require answers that require us to think beyond just simple linear solutions. So, how will we optimise the outcomes from medicines and minimise harms? What services will be required to complement and enhance existing services that exist? How will we evaluate those services implemented in complex healthcare systems? So research is continuing to produce these new findings. But however, simply identifying the problem, which is often sometimes what we can do very well in our pharmacoepi research, but how do we use that to translate that into practice to care for those people who have multimorbidity, who are on complex medication regimens? And this has led to an increasing interest in implementation research, which is the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice. So just like the methods and the science that underpin both the discovery of new medicines and our pharmacoepi research, we also need to look at the scientific study of the methods to translate that evidence into practice. Just like other areas of science and research, there's a range of interventions that have emerged to promote the systematic uptake of research findings and other evidence-based practices, such as optimising the outcomes from medicines, enhancing prescribing, enhancing administration and use of medicines. And despite significant resources being invested into this research, it remains a consistent finding that they have variable success, with obvious implications for the quality of patient care, but also the cost to governments and health systems when they fail, and to cost them to implement them in the first place. So, trying to understand what will work, when will it work, in what context will that work? So, for example, the many different strategies influencing prescribing practices and performance of prescribers has developed typically based on different theoretical perspectives and assumptions, about changing behaviour and habits. Intervention methods are typically characterised by the Europeans in this paper that was published in 2009, and they refer to them as the 4 E's: education, engineering, economics and enforcement. The paper is entitled Soft Regulations in Pharmaceutical Policy Making. So the first of those 4 E's was around education. So that can range from simple distribution of printed materials to more intensive strategies involving educational outreach, or other terms used are educational visiting or academic detailing. Monitoring of prescribing against agreed guidance, the audit and feedback. And other interventions might be focused on specifically enhancing communication to patients, and other countries have used education to patients as well. Public campaigns involving doctors and patients. For example, campaigns around antibiotic use. And I'll touch on these in more detail as I go through. Their concept under engineering is that it refers to the organisation or managerial interventions. It might be structured programs to introduce new drugs. And again, might be thinking about targets, percentage of statin prescriptions that are generic in some countries. So engineering the system to get the outcome that they're looking for. Economics is another approach, and that perhaps is more self-explanatory, where it might include changes in insurance schemes or reimbursement schemes, patient co-payments, for example, or pay for performance measures. It might be devolving hospital budgets to clinicians or to areas. It might be, for example, restricting access to certain drugs that are high cost. And then enforcement. And so this really is using regulatory approaches. And again, sometimes in that first dot point, I see that some of the epidemiological research which has highlighted issues, for example, around opioid use. Certainly in the United States, in Australia, we have increasing use of opioids, and we have a lot of research now highlighting the rapidly increasing use of opioids in those countries. And so we're using that information to inform both regulatory processes, economics, engineering, and also education. But antibiotics is another good example where an enforcement strategy might be where there is prior authorisation required, or it's regulated that certain antibiotics might not be available routinely. There might be mandatory generic substitution. So this is just an example of the classification of one approach that the Europeans use, the 4 E's: education, engineering, economics and enforcement. In this paper, though, they comment that some of these soft regulations using these approaches, might lead to higher conformity and uniformity, and they refer to not at the individual, but in this book, The McDonaldisation of Society, they highlight this may be beneficial in certain situations. However, there must still be room for the individuality where pertinent. So a lot of the interventions that were described in some of those soft regulations or in the 4 E's are often about standardisation. But as I tried to highlight in the start of my presentation, we've got increasing multi-morbidity, increasing polypharmacy, an ageing population. There's a lot of difference between individuals that the clinician has to care for and the health system. So there does need to be room, and certainly in many countries there is a focus in our health systems to putting the patient at the centre of that care and trying to make decisions in their best interest. So upholding standards and good standards don't always mean that standardisation is the best approach. It might be, but we need to take that into consideration. And they further go on to highlight that there are few peer-reviewed studies analysing the effects of health policy reforms targeted to doctors and patients. And furthermore, there is limited knowledge about the potential for cross-cultural learning and transferring models between different healthcare systems. Because you can imagine that enforcement in one country, or the rules that might be able to be put in place in the regulatory environment in one country, might not translate to another country. And education might look very different depending on the context in which that education is being delivered. The engagement with doctors might be different in one country compared to another. So this reflects the fact that it may be difficult in reality to transfer some of these initiatives. And the ease of transferability will depend really on the similarities and also the differences. Having worked in and visited many countries, ambulatory care or primary care in one country can look very different to what it looks like in Australia, for example. So what we might implement in primary care in Australia could be different, but hospital systems might be different as well. And so it does vary depending on the extent of perhaps the difference between a hospital and a primary care environment, but also budgets and fiscal implications for some of this work. And I've just included this because I'd just like this particular part to summarise. They highlight, and I'll just read what they've said. The main components of these soft regulations are standardisation, monitoring and agenda setting. However, the impact of these new modes on health provision and overall costs is often unknown, and the increased focus on monitoring may result in higher conformity and uniformity that may not always benefit all key stakeholders. Alongside this, substantial growth of auditing associations controlling a diminishing minority of people actually performing the task may be costly and counterproductive. So I think what they're trying to highlight in this approach is, in this particular paper, is that, again, the same standards of research that we apply in other areas should also apply in implementation research, because they may have unintended or counterproductive outcomes. So if we look to the Cochrane collaboration, the Cochrane Collaboration's review group on effective practice and organisation of care has identified 4 broad categories for the implementation strategies. So these are in a little bit more detail than the 4 E's. And I'd just like to take you through some of these, and then I'll pick out a few to focus on, to elaborate on a bit more. So in their implementation research categories, they categorise them as delivery arrangements. So changes in how, when and where healthcare is organised. Financial arrangements are there again, like the economy in the other one. Governance arrangements, which are the rules or processes that affect the way in which power is exercised. So governance does include both engineering, if you like, and enforcement. And then the implementation strategies. And these are really the behaviour change strategies for healthcare professionals. And I want to focus more on the implementation strategies. And there can be a whole variety of these implementation strategies that they have now categorised, and I've got the reference up there for you. They've changed them in 2015. But one of those is about organisational culture. Now, audit and feedback is one of these strategies. But even when we look at audit and feedback, which is described as a summary of that healthcare worker's performance over a specified time period and given to them in a written, electronic or verbal format, the summary may include recommendations for clinical practice. But when we look at the evidence for audit and feedback, the evidence can vary, again, depending on the context that it is delivered and who's giving the audit, who's undertaking the audit and feedback. So again, when we look in this area of implementation science and implementation research, we find that something like audit and feedback, it does have evidence for its effectiveness, particularly in influencing decisions around medicine's use, as one example. However, what we know is that the effectiveness of that will vary depending on who is delivering the feedback. So even though it's an effective intervention, we do need to think about the methods that are used. So again, the rigour that's applied to something like audit and feedback. There can be other things like clinical incident reporting, and I know there are some of you in the audience that use clinical incident reporting, adverse drug reaction reporting, ADE reporting at a hospital level to raise awareness of particular issues. And I should have said that's the same with audit and feedback. Often audits are undertaken to identify a problem or drug utilisation research, and then interventions to improve those outcomes follow. Monitoring of the performance, communities of practice, many continuous quality improvement activities, educational games, educational materials. So, lots of resources are prepared, aren't they? Following, again, if I use the opioids as an example, a lot of resources have now been developed recognising the increasing problem associated with opioids, particularly, as I said, in my country, in Australia, where the pharmacoepi and drug utilisation information is really highlighting that this is a problem. We would be using audit and feedback to try and address some of that problem. First of all, identify where the problems exist. And that might reveal, for example, that we're seeing increasing use of opioids post-surgery. And that's an area to intervene and provide some educational support. We've also drilled it down to recognising that some of it relates to the particular type of opioids that are being used. Patches and sustained release formulations, high doses. So again, thinking about how do we understand the patterns of use and then tailoring the education the implementation strategy that's appropriate for that. A couple that I want to particularly highlight in this workshop are around educational outreach visits and academic detailing, and these are personal visits to a clinician, most commonly a doctor, but they can be other health professionals, to provide information and advice that's tailored to that individual person that you're interacting with. And there's a list of other interventions. So as you can see, the implementation strategies, there's a whole variety of them. Perhaps like the many different methods that might be used in pharmacoepi to try and better understand or answer a question that we have. So not all implementation strategies have the same level of evidence for their effectiveness. So, sorry for that, just as I was saying, not all of the implementation strategies have the same level of evidence. And this is a taxonomy of the professional behaviour change based on that EPOC, or the Cochrane EPOC group's implementation strategies at the high level. And it's these ones here: the audit and feedback, reminders and recalls, interactive educational meetings, and academic detailing, which have the highest levels of evidence for the consistency of effectiveness. But also, patient-mediated interventions also have been shown to be effective. Now this again highlights that that might be different in different countries, in different cultural contexts. And I've already highlighted that audit and feedback might have more effectiveness depending on the design and implementation of the strategy that is used. And increasingly, the recognition of these models have developed in different ways, and they're underpinned by different theoretical perspectives. There are a number of similarities with the theories that underpin these implementation strategies, but really at the heart of it is that they recognise the many interacting and complex influences on all of us as our behaviour, our own personal characteristics, the practice environment in which we work, and the local community. By that I mean the local context, whichever country or setting you're from, is going to vary. There are a number of different professional change theories that have been developed, and you might have different names for, know some of these better than others. Diffusion of innovation and social marketing, the trans-theoretical model, many different theories underpinning our behaviour. And again, talking to an audience like this, you will have different, I'm sure, theories to describe human behaviour in your own context and practice where you come from. But we, I suppose, emphasise in this implementation science field and in the implementation strategy field, underpinning our work by looking to the theories for why people do things. If we just really understanding some of that decision making that occurs is very complex too, and changes often. Perhaps motivational theories, action theories, stages of change theories, focus on behaviour that is amenable to change. Some of us, it can be about beliefs, our own attitudes, our own self-confidence to make those changes, actual and perceived external constraints. This is a diagram from the Drug Utilisation Research Methods and Application publication from 2016, published by the Eurodrug group. And it was just to visually bring together some of those different theoretical frameworks and how understanding them across different stages, and when you might use them from awareness raising. So that might be the public campaigns for education. It might, in terms of the stages of change approach, that might be where people are in the pre-contemplation phase. So think an antibiotic awareness campaign, getting people to understand that antibiotics might not be the most effective intervention, they're not the most effective intervention for many common viral infections, or they're not appropriate for viral infections. And then knowledge building, moving people from that pre-contemplation to the contemplation phase. So that might be guidelines, evidence summaries, reviews, giving a lecture. Preparation, where there might be skill development, where you might need motivation, and then maintenance or reinforcement. As I said, people's clinical conditions, the environment in which doctors and other health professionals, pharmacists, researchers are making decisions is constantly changing. So we need that reinforcement. So that might be, and all of this is happening across time. And different interventions might be more appropriate for different ones. The complexity of practice change and the underlying theoretical frameworks. One of the interventions, academic detailing, is placed under skill development in that model, but it also has a place under motivation and reinforcement. So again, some of these implementation strategies can really, be more effective at different times, whether you want to use something for awareness raising, that might be education of different types, but where you want something more active, more action, to really influence and change behaviour, you might need to use a combination of interventions or something like academic detailing, where it's personalised to the person that you're interacting with. And I'd like to come back to that. Social marketing is a term that maybe some of you may have heard of, but that draws on a body of knowledge such as psychology, sociology, and communication theory. And really, again, with the social marketing framework, it's applying commercial methods of marketing. And commercial methods of marketing really highlight understanding your market, understanding the person whose behaviour you're trying to influence. And so it's really applying those principles so social marketing is applying those marketing principles to improve social and health problems. In many areas it's been about injury prevention, it's been about smoking cessation, it might be about reducing alcohol consumption. It could be aimed at an entire population, like road safety, seat belts. So it's been used in a variety of settings. And social marketing provides a mechanism for encouraging individual behaviour, making individuals aware and influencing their behaviour. And in the hospital setting, it might be things like hand washing, really to reduce a lot of emphasis on reducing infections and reducing antibiotic use might be around hand washing and hand hygiene. Rather than having a big strategy around the antibiotics, might be about hand washing. And that might use a social marketing approach. And to do that, would try and understand, why do people not wash their hands in between patients or after touching a patient, touching their environment? So really trying to understand why people do things will lead to interventions that will hopefully change their behaviour. So the same principles apply in trying to understand, why do people use antibiotics to treat infections where they might not be the most appropriate choice? So I think, there's a lot of information here, perhaps for more reflection, but applying these commercial marketing techniques to social marketing, I think helps us to really focus our attention on what information do we have to gather to understand why people do things and in what settings do their behaviour. So if I think about social marketing and try and explain that a little bit more, it is about this principle of exchange. We recognise that to get people to change, if we use that example of hand hygiene, which I imagine in many settings to get people to stop doing what they're doing, we have to offer them a clear benefit for them to change their practice. And, you know, the importance, I suppose, is that when you offer that different practice, it has to be of appeal to them. It has to be something that fits in with their own concepts around modifying their behaviour. It has to have some appeal for them in return. People don't change their behaviours easily. At any given time, only a percentage of your audience will be ready to take action. And I can see, looking at the audience today, this idea of thinking about the implementation strategies that we've got. For some might be, you've done this, you're implementing successfully interventions in your own practice, context, country. For others it might be something new. But for some of you, it will be a process across time to think about these implementation strategies. Maybe you're more interested in gathering the research that you can give to other members in the healthcare team to implement education strategies, to translate your evidence into practice. But just like much of this research, not everyone will be ready to take action. So I would be hopeful if only a few of you would be interested in taking action around implementation strategies, taking your pharmacoepidemiological research, the knowledge that you've got, and putting it into practice for improving health outcomes for patients. But one of the key principles of this is that it's about voluntary and mutual beneficial exchange. So one of the other principles is around market segmentation and targeting the market. And this is where I think we use our pharmacoepi research, is we can really look and see where sometimes drug utilisation problems are occurring, or drug use problems, where there's safety signals, and use that information to inform and design our implementation strategies. We've got a vast amount of information now on safety of the use of medicines. How do we use that to bring about this behaviour change and effectively make a difference with the information that we've got? I think one of the things also is that, as I've highlighted, is that, you know, we've got a large number of systematic reviews now that have looked at the effectiveness of a number of these implementation strategies. And our research to improve our understanding of how to design and evaluate interventions, to use theory in the implementation of these complex interventions, is increasingly being done to undertaken to identify what factors modify the effectiveness of the interventions. One further thing that I would like to highlight to those of you interested in implementation science is the work of Susan Mickey and her colleagues, and they refer to this as the behaviour change wheel, and they highlight at the heart of that is often the capability of the person, the opportunity for them to use the information and knowledge, and the motivation to do so. And they've got, and again, on that outer wheel are some of those things that are included in the Cochrane collaborative implementation strategies and referred to in the European work. So again, summarised in this behaviour change wheel are some of the implementation strategies that I have been discussing and where they fit. Again, a little bit like the other infographic that I showed you, it's highlighting that where you want to place education or persuasion or incentivising health professionals to make a change, or where there's coercion, where there's more training. So it's a useful approach, if you haven't seen this before, to use the implementation science approach and behaviour change wheel. And in the behaviour change wheel research literature, they give you information on, for example, education. They describe which one of those Cochrane categories it falls into, and then some behaviour change techniques that you might use to address and that might be included in that particular type of intervention. So it's a way of organising your interventions and describing them in your publications as well, in a systematic way, so that they can be compared between different settings. So we know that prescribing is really a fundamental part of medical practice, and yet it's still very complex. So all of the things that I've been talking about up to now, really highlight that we've got complex systems, and when it comes down to an individual doctor prescribing a medicine for an individual patient in front of them, it's still a complex task, even today, despite all that we know about the safe and effective use of medicines. And there can be so many factors, can't there? The different biochemical properties of the drug, but also other factors influence the behaviour of the doctor who is making that decision. And just a summary there, I won't go through them all, but doctors' own training, their own beliefs about medicines. Maybe pharmaceutical company promotion, or local guidelines, or a local opinion leader. They're all going to influence the decision making of that doctor when they come to write a prescription. So as much as we know about medicines from all of the research we've done, it comes down to that doctor with that patient in front of them to make that choice. And recognising and understanding these many different influences will help us to develop more successful strategies to enhance and improve prescribing. There's lots of different theoretical domains, even around how doctors make decisions around prescribing. And one of these, which I'd just like to bring to your attention, is around memory, attention and decision processes. And they've been identified as relevant to doctors' behaviour and decision making. So if you think about that, memory, attention and decision processes. So that leads then to this idea of cognitive bias, and a tradition of what is often referred to as heuristics. I'll leave you to look that word up. Some of you have got your devices out to look that up. And biases. But these are sometimes the quick rules of thumb that we each have to get to the right answer. It might be looking up a resource that you trust to quickly get to an answer, or it might be deferring to a specialist, because most of the time when we ask a specialist in a particular area, we're confident we're going to get the right answer from that specialist. But that can lead to error, because they might not always be right. And this is what we mean by cognitive biases. So cognitive strategies work well, often, because they're fast, they commonly lead to closely approximately the right answer. But they are also associated with bias. And so you might be familiar with the fact that there can be errors in clinical reasoning. We can all make errors in clinical reasoning. And this is a paper that describes some of those. There's lots of literature on clinical reasoning, which if you're interested in, you can look that up a bit more. But what that means in essence is, I'll just this cartoon highlights, it looks like a duck, it sounds like a duck, it quacks like a duck, but it's not a duck. It could be a goose, is the junior doctor at the back. So it highlights that in our decision making, and I think we do this a lot in our pharmacoepi work as well, is that we often are looking for patterns, aren't we? And our pattern recognition can lead us to develop certain understanding, but it can also lead us to the wrong answer as well. So keeping in mind our clinical reasoning and that this is one of the things that sometimes leads to medical error, here is another one. Or perhaps this one is more universal. And we rely on these so commonly now, and sometimes going to in the taxi yesterday, coming back to the hotel, I handed over the taxi driver the card that the concierge has given me, which was going to assure me to get back to the hotel. So it had the hotel address on it. I handed it confidently to the taxi driver and was hoping that I was going to come back to the Wyndham Hotel. He looked at it. He then phoned somebody else. He then looked it up on GPS. He then plugged it into the GPS. Then he followed absolutely the GPS path to get back to this hotel. If any of you are staying at the hotel, you'll notice that there's a lot of roadworks going on outside of the hotel. This was not factored into his GPS, and we ended up a long way in the wrong direction. And so that for me was a cognitive error I made in handing over the card, hoping I was going to get in the right place. It was also a really interesting experience where he was driving the car and he had his mobile phone, which he spoke into, and then it converted it into English at the same time. It was amazing. Not all the words translated exactly as intended. So there's lots of errors in clinical reasoning, which I refer you to that paper, but I just wanted to highlight one in particular, which is around errors in management. And as a clinician, it might be that the treatment seemed to work well on the last patient who had the same problem. Most of my colleagues were very keen on this new drug, so I used it too. So there's a whole lot of examples where I was too concerned about possible side effects and underestimated the potential benefit of treating with drug X. So despite all the information that doctors have, their own experience can influence their decision making and lead to cognitive bias. So if they've seen good outcomes with a patient on a particular drug, that might inform their practice more than any research and evidence because of these cognitive biases. And sometimes that gets them to the right answer, but other times it can be lead them to the wrong answer, a medical error. And unfortunately, this risk and uncertainty that occurs, it predisposes, we know what we want to achieve. And sometimes this flight from uncertainty and ambiguity is so motivated that we create this pseudo-certainty. And this is a bit like some of the strategies that are used that lead to standardisation. So we try and create pseudo-certainty. So designing behaviour change interventions, as I said, the improving the implementation of evidence-based practice and public health depends on behaviour change. Just really quickly, I just wanted to highlight this is some work from Australia, Our Future World, and these are the kind of mega trends that they see are happening. But one of the things that I think is going to and these are going to factor into some of our implementation strategies in the future, and particularly the virtually here. So that will influence some of our new strategies, because we'll use different methods of interventions, and we'll need to adapt to those as our environment changes. But interestingly, the expectation for face-to-face interaction, despite the high participation rates in social media, is still evident in the research. So society is still, this was just highlighted in this, that even though there's a lot of virtual interaction, we shouldn't abandon the concept that humans and connectedness and face-to-face interactions might still be important ways, and importantly in implementation strategies, to influence behaviour. It might be the expectation for fewer but stronger social relations. So I think in implementation research this is going to be important, and some of the work in Australia's looking to our future highlights this, and I just show this in a bit more detail. So these, what they refer to as porous boundaries and digital immersion. So I think we need to be paying attention to how do we use the research evidence we've got against a changing way in which we can influence behaviour, and tapping into other science as well. And this was just to show you, in a country like ours in Australia, which is very small in comparison to this amazing country in China. I mean, it's so small in comparison, but it was just to give you a bit of an idea about a day in our healthcare system. 850 babies are born and 440 people die. But it's also 26,000 specialised community mental health care services are provided. Mental health care in our country is becoming an area where we are very focused on, because it's not only chronic disease, but it's some of the mental health problems as well, and mental health is often a very common comorbidity for people with chronic disease. So again, I just wanted to highlight in this slide that in that top right-hand panel, that's just showing you the number of health practitioners we've got. And you can see that we have more specialists, medical specialists in our country than we have general practitioners. And that's what I meant at the start of this. The type of implementation strategies and where we need to affect change will depend on your country's healthcare system, and also the types of conditions that you have. And the bottom panel was just to highlight the differences in the type of disease burden, which varies across age. So you can see in the 45 to 64-year-old age, it's musculoskeletal conditions that are the most common. But by the time you get to the 8th and 9th decade of life, we're looking at dementia and coronary heart disease. So again, if we're thinking about understanding the medicines in those different age groups, and then who might be caring for those people, then our implementation strategies are going to need to take that information into consideration. And again, just to highlight again the landscape, the type of people we will be interacting with will depend on where we are focused, whether it's primary care, hospital, aged care, and it's going to, I just wanted to highlight that, a GP in Australia is a general practitioner, so that's a primary care doctor. And the primary care doctor in Australia is often put at the centre, as they're the ones that might be having the long-term clinical care of a particular patient. So just a couple of quick other slides which to sort of highlight the complexity in science for those of you are thinking about how we apply this implementation science using in what is very complex healthcare systems. How do we interact with different clinicians? And this comes from some research by Jeffrey Braithwaite and his colleagues that they've published this work. And this was just a network diagram highlighting time points of collaboration among cancer clinicians and researchers. That was 2012, 2013 and 2015. So interactions between researchers and clinicians is becoming, greater and greater. So even more challenges for the type of research about effectively implementing change. And this was the organisational complexity just in one part of the hospital. And that is a schematic of the medication advice-seeking network in an ED department. And what you can see is that the nurses mostly talk to the nurses, the doctors mostly talk to the doctors, the admin talk to themselves, and so the opportunity for influencing decisions is complicated by these patterns of communication. So I just want to quickly show a couple of examples, and one of them was around antibiotics. We know that that's an emerging global problem. It's already here. We know that it will affect surgery, obstetrics, intensive care. It will, affect so much of our clinical practice if we don't get that right. We know that antibiotic resistance is rapidly developing, and more quickly as we look at the more recent antibiotics that have come onto the market, how rapidly now from time to reach market to resistance developing. We know, as I said, there's higher impact. But preventing and managing infections, infection control, promoting and prolonging the effectiveness of antibiotics. Many countries will have introduced antimicrobial stewardship as an education strategy, but also as an enforcement or regulatory and policy. But some drug utilisation data is really underpinning this. So from Australia, over 10 million, again a small number I know in comparison to many countries, but what that meant was 45% of the Australian population was supplied at least one antibiotic in 2013. So 1 in 2 Australians got an antibiotic. If we look at patterns of use across time, we can see that from 1994 through to 2015, it takes us up to 2015, but this only in there between 2002 to 2005 did we see a slight reduction in antibiotic use. And now we've got antibiotic use expressed in defined daily doses per 1,000 per day. Now some of that might relate to increasing use, or importantly, it might relate to different capture of antibiotic utilisation. So now we might be capturing a bit more from the hospital as well as the primary care in this data set. So understanding the pharmacoepi data is really important. Also looking at the age group in which that antibiotic use is occurring. And you can see that it's not all in the young children in Australia, but really our increasing use of antibiotics is actually occurring in older people in the 6th, 7th, 8th, 9th decades of life. And perhaps that's not surprising, given antibiotics are increasingly being used in surgery such as hip and knee replacements, in cancer. So we're seeing increasing use. So using and translating this information into education. And again, that's just showing you there the utilisation of the antibiotic class by ATC code. And we can see that the patterns have not really changed that much between penicillins, the macrolides and the quinolones. In Australia, we're using some of this data to inform education. So that first step, awareness raising for clinicians. So we have the Australian Atlas of Healthcare Variation, so that at a country level we can see what the different patterns of healthcare variation is. And this is just one showing cellulitis, for example, so you can look to see what the different patterns of use around cellulitis. For those of you who might know Australia, will see that unfortunately in our Northern Territory, where we have a lot of Indigenous and Aboriginal people, we've got high levels of cellulitis occurring, relative as a proportion of that population. So when we come back to understanding these patterns at a population level, we need to drill down and think about that at a local level, so we can think globally but act locally. And we know in nursing homes, for example, there's increasing antibiotic resistance. So again, we might need different strategies in that setting as well. So just to finish on, one of the interventions that has been referred to in my presentation is academic detailing, which is one of the health professional behaviour change strategies which has been shown to have high levels of evidence for consistently being effective. It was first arose from a publication in 1983 by Professor Jerry Avon and Stephen Sumarai, and that paper just referred to there briefly. Frank May, who's in the audience, was really saw this idea and brought it, as we would say, down under, but developed a service called the Drug and Therapeutics Information Service in 1981, which I've been pleased to be, and now as the director of that service, been involved for nearly 27 years, providing this to many clinicians across Australia, and certainly in our home state in South Australia. We were, I suppose, fortunate in the first application of this, applying our understanding of utilisation of medicines. It happened to be a class for the non-steroidal anti-inflammatory drugs, and looking at, in this case, reducing some of the adverse effects associated with non-steroidals back in the early 1990s was the recognition of peptic ulcer disease and bleeding risk. And so we undertook an academic detailing program to clinicians in an area around our hospital. And what this showed was, following that intervention, there was changes in the admission to hospital of people with peptic ulcer at bleeding risk. And it wasn't about attributing causality. I'd like to really emphasise that, but it highlighted that you needed to look at evaluation of your programs using the right methods. And we were able to show a decline in people presenting to hospital in the area in which the education had been delivered using this technique of academic detailing. So we've had over 25 years of using this technique in Australia, and I just, still, this is relevant today. Clinicians, this was from a paper in the BMJ, clinicians rarely accessed, appraised and used explicit information. So despite all of that investment in guideline development, what clinicians used and relied on was brief reading, mainly interactions with each other, and with opinion leaders, patients and pharmaceutical representatives. So if you think back to those complex network diagrams I showed you, there's so many more people in this space. So I think it's even more important in 2018 to develop effective, successful educational interventions using this technique, because it allows you that face-to-face interaction to deliver information that's relevant to the person you're interacting with. Because it's still face-to-face information, you're using a structured framework, you're understanding the motivations for current practice, the individual behaviour change that might be required, both at an individual and system barrier. We've been working with some colleagues in Norway who a couple of years ago now implemented a similar program around non-steroidals, but they were highlighting the prothrombotic risk, and they saw similar changes in terms of patterns of use. So again, it's about using this technique as appropriate, because it is about one-to-one. It's about providing this in a way that meets the health practitioner's needs as close as possible to real-time practice. It moves interaction beyond communicating just information. It involves understanding existing behaviour. It requires us to work out where people are at, not just what where we want them to be. So thinking about so many interventions and approaches and implementation science, we really have to understand the person who we are trying to influence. And it really focuses on achieving voluntary action. Bearing in mind that, as I've highlighted, there are a number of other implementation strategies that might require policy change, they might require economic change, they might require governance measures. They all might be important in achieving change. I'm just now highlighting down that after all of that, still have to influence an individual clinician because they're the ones that will be writing that prescription or changing that medicine for that patient in these complex systems. The theoretical basis for academic detailing is found in social marketing, diffusion of innovation, and adult learning theory. And it really brings the best available evidence to the place at which care is delivered and can be tailored to the level of knowledge, interest, and responsibility of the person visited. So it can bring all of that evidence from our pharmacoepidemiological research, but other areas of research, and be tailored to that person that you are interacting with. But, just in closing, I suppose, it's thinking about the ensuring that just like any other strategy, that the people have the competence and capability to use this technique well. And just like the EPOC taxonomy, you'll find often in the literature that there might be references to people use the technique of academic detailing, but we have to look at how did they use it, how did they apply that. So as researchers in this group and in this audience, perhaps more familiar with some of the requirements of our methods we might apply in other areas of research, we do need to bring that to the front of our mind when we're looking at implementation research and trying to evaluate the effectiveness of interventions, because they may not include enough information for you to look at the fidelity or the way in which those interventions were delivered. And I think that's really an important part of this workshop. That to do these things well, there might be training that's required, might be training in communication, it might be training in actually appreciating and understanding the complexity and the challenges of when clinical decisions, embracing uncertainty. Training programs do need to be underpinned by the principles of academic detailing. Given our work in Australia, we've developed a workshop around that to try and enhance the skills of people to undertake academic detailing, and it involves role-playing and interactive methods. Again, this is from Professor Jerry Averin's work in the United States, and also Professor Mike Fisher, who leads the NARCAD group. But they've developed also academic detailing programs, and now they exist in many countries in the world. And they require, planning and also training of people. Maybe to give a little bit of local context, in Australia, our visits with doctors would last about 30 minutes, and we don't pay the doctors to visit them, and they don't pay us to visit them. It's funded through our federal government or through local state governments. It can be funded by our hospitals and funded through aged care providers. So they're seeing that this is a technique that brings about behaviour change. So I think, and again, that just highlights one example where it might not work in other countries, but it might also be something that can be tailored to the local context. But it is underpinned by theory, practice, and evidence. And how you design programs that might be multifaceted might include something like academic detailing, audit and feedback, system change, patient tools, educational materials. So there can be a variety of strategies that might be packaged together in a particular multifaceted intervention. So they might not be just single ones. And how are these programs designed and identified? And I highlight that second point, which is around, is there a drug utilisation issue? And so in preparing and designing these programs, understanding use of medicines through a range of approaches is really important to being able to tailor and develop these programs. And certainly there's been a range of them that we've used, and all of them have had this at the heart of them, medicine's use. And as you can see from that example of the therapeutic programs, and they've changed across time. A recent one that we've done related to chronic obstructive pulmonary disease, we've had an influx of new devices, new drugs, so it changes across time. So really then in thinking about the evaluation, certainly many of the methods to evaluate some of these programs have used drug utilisation and pharmacoepi methods to evaluate. Often they're looking at changes in drug utilisation. So if you're implementing a program to enhance the outcomes, for example, around diabetes management or the management of chronic obstructive pulmonary disease or heart disease, often they've required looking at changes in drug use, and they're methods that you're very familiar with. But also I just wanted to finish by highlighting that perhaps we also need to look to other methods for evaluating some of the implementation methods that we use. And a realist approach was first described by Ray Pawson, and there are other papers there that might be of interest as well. It's a methodological orientation or a broad logic of inquiry that is grounded in philosophy of science and social science. So we've had implementation science, and now we're moving to philosophy of science and social science. And it sits, broadly speaking, in a way that it argues that we can improve our understanding of reality because the real world constrains the interpretation we can reasonably make of it, while our knowledge will always be partial and imperfect. For those of you who've worked in this area of pharmacoepi for a long time will know that, we're always striving, to try and get better and better understanding, better methods to try and answer those questions. And I think one of the things is that there can be many factors influencing why a strategy and implementation approach is going to work. And using something like a realist approach really makes us focus on trying to understand what the mechanisms is. In what settings will it work? How, because we've tried to understand how it works through understanding these mechanisms. And this is published in this paper and in some training materials, which is a pictorial representation of the mechanisms. So you do your program activities, and then that leads to the reasoning, the preferences, the collective beliefs of the group, and then that'll inform the program outcomes. But trying to understand those decision choices is an important part of using a realist method. So there are a number of papers now in the published literature using mixed methods, using the quantitative approach, but also adding in a realist approach to the intervention, behaviour change strategies to influence prescribing and use of medicines. And I think that this is going to help inform our policymakers and our funders, because it will give them more information to know when to fund something, in what setting, and who is the best recipient, if you like, of that intervention. So a realist approach therefore looks for interactions among the opportunities or resources provided by the intervention after the reasoning or responses of the participants. And yes, as I said, used as part of a mixed methods approach. And an important principle is that the causes of outcomes are not simple, linear or deterministic, which I think you'll see has been a feature throughout my presentation, is that we are operating in a complex environment, and also there's a lot of uncertainty around decision making that we need to understand. We can use our pharmacoepi data and translate that into optimising outcomes from medicines, but thinking about this working through and understanding of why things work. And this is just the final slide, is individual behaviour is influenced by a whole variety of factors, and our education and training is just one of those factors. And we need to try, I think, to apply the same rigours of research and understanding to implementation science and to the interventions we implement, as we did in developing, designing and undertaking the pharmacoepi methods in the first instance. I wonder if there's any questions that people would like to ask me about that. I know it's hard in this forum. Yes.
I just wanted to ask you, in terms of the background of the academic detail, like what sort of background are they usually from, and also are there any plans to sort of expand that academic detail to other parts of Australia? I noticed that you said that there were quite a few, like thousands of cases done in Southern Australia. Is there like any parts, like to other, any plans to expand that to, Queensland, Victoria, like other states as well?
A couple of the slides that I haven't included, certainly in Australia, in 1998, Australia implemented a national program through the National Prescribing Service. It's now referred to as NPS Medicine-wise. And through that federal government funding, they have implemented a service across Australia. So all states and territories have people trained in academic detailing principles. They referred originally to them as NPS facilitators, and in Australia in the last 25 years, approaching well over 300,000 visits to doctors across Australia have using this technique. NPS medicine-wise use a range of interventions. So they also use audit and feedback, patient-mediated, and certainly still in 2018, having been involved in developing some of the programs with them and doing the training for them for 18 years. Yes, it certainly is a national program in Australia.
In that case, is there any potential for this to be expanded to other health professionals, like pharmacists, for example, nurses, like any other?
Yeah, I suppose that's what I was trying to allude to in this workshop, was that academic detailing is now used in residential aged care, for example. Some of the interventions have been around, first of all, doing the drug utilisation to recognise problems associated with antipsychotics, benzodiazepines, opioids, and then developing an academic detailing program that's been rolled out across Australia by the University of Tasmania called the Reduce program. But it's also used in the hospitals as well, widely, in different areas such as post-op pain relief, opioid use again. We're using it in aged care around antimicrobial stewardship, so in different settings. It's mostly used in primary care in Australia, that technique, but it does have application in hospital and other settings. The type of person, the background, I think was mostly your question. A lot of pharmacists with a background in pharmacy, but also other health professionals, nursing, doctors. I've had the privilege of training an orthopaedic surgeon who's done academic detailing around shoulder injuries. And we've used it in palliative care as well. So a range of, because it tailors the intervention to the individuals that you're interacting with, their clinical literacy, their scope of practice, and what the situation is that you're trying to influence. So we've used that widely. So yes, NPS has had 20 years, has celebrated 20 years this year.
Thank you very much.
Thanks, Deborah. Nice presentation. Laura Fanning from Monash. Just a quick question, more sort of on the ground. When you're working with the clinicians, how do you engage them when they're sort of working in those busy, complex environments?
Yeah, thank you very much for that question. In those situations, again, I think that's why in giving this overview is that just because we have done all of the literature review, gathered all of the information, it's not going to be necessarily of relevance to every clinician, and I think that's what you're highlighting. So on the ground, that's why I think a technique like academic detailing means that you are open to learning from that other person. You're willing to listen to, some of the issues that they're facing so that you can tailor the information that resonates with them. And they're usually very appreciative that someone is not coming to tell them something, but to share information with them that they can apply in their practice. So I think it's the starting point. And if you come back, in Australia, we have a policy called the Quality Use of Medicines, and at the heart of that policy is partnership and collaboration. If you come with a view that you are going to be consultative and work collaboratively, I think that is a way to engage them. I think also the time is really is really attractive, particularly in the hospital for junior doctors. We've just developed a program. The average time in the hospital for a one-to-one visit is about 17 minutes. And they really appreciate that because they don't have to go off for an hour's teaching. And for the hospital administration, getting together 10 junior doctors for an hour is 10 hours less work time. But if you take them one at a time for 15 minutes, you do the maths on that, it's a lot less staff time for the clinicians in a busy hospital. Does that make... Thank you both so much for your questions. But I suppose this workshop was also to highlight that it's within a framework of implementation science. And I think some people might say, well, we live in a digital age, but the face-to-face connection and being able to tailor that information is still very relevant in 2018, because often, as I can reiterate, the clinicians are having to face multi-morbidity, and what they really like from an academic detailer with that broad background is they're not just coming to tell them about, particularly general practitioners, about how to treat diabetes when it's not in the context of all of the other conditions that doctor might be facing.